in Jacksonville, Florida. From the International Karting Federation Sprint Grand Nationals, the Entertainment Sports Programming Network presents the IKF National Championship 100cc McCulloch Light Amateur.
From Jacksonville, Florida, the site of the International Karting Federation Grand National Sprint event under slightly misty skies, 15 feet from trackside, this is Chuck Allen along with Gus Trader. Gus, give us a lineup on the 100cc McCulloch Light.
Okay, we have 22 entries, Chuck, and with a fast time in this qualifying was number 14, George Ito. Outside is number 11, Todd Barron. In the second row, we got 29, Scott Sullivan.
Hi, and welcome to the June 2025 issue of IGIE. My name is Phillip G., section editor for IGIE's section on historical considerations. Boundaries are all about perspective, and it often takes an outside perspective in order to define and expand them. After all, rules are meant to be broken, a quote attributed to the famous General Douglas MacArthur. In the 1970s, a pair of teenage brothers traveled across the country to compete in high-speed go-kart tournaments. Fueled by a desire to win and encouraged by parents who inspired them to push their boundaries, they worked hard and taught themselves how to build engines, overcome obstacles, persevere, and eventually win national championships in go-kart racing. The younger of the brothers ultimately took these valuable life lessons into medicine, where he has worked tirelessly to push the boundaries of interventional endoscopy. Just like in the world of racing, he would have to overcome obstacles, think quickly, and weather the ups and downs, but he would push through and refuse to quit, believing that with hard work and a steadfast resolve, he could solve problems and take care of his patients with whatever tools he had in his hands. We are therefore excited to tell the story of Dr. Todd Barron, who is our distinguished guest for the Historical Considerations section of IGIE. Dr. Barron was the younger of the two go-karting brothers, who grew up in Florida and earned his bachelor's degree and medical degree at the University of Florida, in postgraduate residency and fellowship training at the University of Alabama, Birmingham, where he remained as junior faculty and started its ERCP program. It was at UAB where Dr. Barron became internationally renowned for his pioneering contributions to interventional endoscopy, becoming the first to describe and publish on the endoscopic drainage of walled-off pancreatic necrosis. By becoming a maximally invasive endoscopist, essentially performing minimally invasive surgery, Dr. Barron blurred and expanded the boundaries of endoscopy. Over his subsequent career, which spanned UAB, Mayo Clinic Rochester, and now at the University of North Carolina, Dr. Barron has continued to push boundaries, often seemingly demonstrating that perhaps there were none. Dressed famously or infamously as Captain America at the World Cup of Endoscopy, Dr. Barron showcased the limits of what we can do at the Digestive Disease Week in 2016 with a truly shock and awe case of endoscopic drainage of a mycotic aortic aneurysm, a feat which summed up an entire career of thinking outside the box. Not surprisingly, Dr. Barron served as the inaugural co-editor-in-chief for our sister journal, Video GIE. Dr. Barron is currently Professor of Medicine and Director of Advanced Therapeutic Endoscopy at the University of North Carolina. As an internationally renowned expert in ERCP and EUS, Dr. Barron was honored as the recipient of the 2023 Rudolf Schindler Award, the most prestigious award given by the ASGE. Dr. Barron, thank you so much for taking the time to do this interview. It is truly an honor and privilege. Tell us a little bit about your background and how you ended up becoming a gastroenterologist and advanced endoscopist.
Yeah, sure. Well, first of all, Phil, thank you for that really kind introduction. And it's an honor to be recognized by the journal, be able to tell my story. My interest in gastroenterology began actually with a lecture. So I'll go back. When I was in medical school, I was really convinced that I was going to be an oncologist, mostly because when I was in pathology, I actually really enjoyed the pathology of cancer in terms of how it behaved and the characteristics. And so during medical school, I did heme and onc electives in my fourth year and immersed myself into both hematology, oncology, did surgical oncology for my surgical elective. So I really thought that I was going to be an oncologist, and I ended up going to UAB on the recommendation of my advisor who was my physical exam instructor. And I really loved that program. And so early in my internship, they gave me an oncology rotation, a medical oncology rotation, of course. And things really didn't turn out as expected with that. And so I decided I was going to do something else, but I wasn't sure. I knew I wanted to subspecialize. And so I went to medical grand rounds. And, you know, the younger people probably don't realize back in the day, medical grand rounds was really a huge thing. Not that it's not now, but really it was mandatory for every resident faculty member unless something was literally emergent. So it was a standing room only. And Peter Cotton was invited to lecture about ERCP. This would have been about 1987 or 1988. And I immediately clicked. He talked about, I remember, you know, relief of obstructive jaundice, removal of stones, and sphincterotomy, things now that would probably be considered relatively basic-ish ERCP, but at the time to me it was totally fascinating because I'd never heard of it. So when I walked out of the auditorium, there were rotary phones outside in the auditorium, the old-fashioned, like a little hood around it. And I remember calling my wife and saying, I know exactly what I want to do. I want to do ERCP, and that's why I went to gastroenterology, just to do, you know, ERCP.
It's amazing. It's like a complete serendipity, and I find it so interesting how intimately tied actually everybody is in our field.
Yes.
So it obviously appears that Peter Cotton inspired your decision to go into gastroenterology and specifically into pancreatic biliary endoscopy. So then tell me about your subsequent training experience in ERCP.
Yeah. So I ended up, fortunately enough, I ended up matching at UAB, which at the time was doing about 25 ERCPs a year. And I didn't really realize, you know, you think you go to a lecture and somebody talks about ERCP, that everybody has ERCP. And then I realized that they really didn't do very much ERCP. And so I really wanted to go to Duke, and I had ranked them number one. But of course, really everybody at that time wanted to work with Peter Cotton and go to Duke. So I ended up matching at UAB, and I was, you know, a little bit somewhat, I guess, surprised. Maybe I was overconfident that I would match somewhere else. And then at the time, I didn't realize, because there were no advanced endoscopy programs at the time and no matching program for sure, that I would be able to eventually learn ERCP somehow. So I almost contemplated not doing, you know, my fellowship, but my wife really convinced me to just go ahead and give it your best. And shortly after I started, within 3 months, the chief of medicine called me in, and that was somebody I worked closely with as a chief resident, and said, I really want you to stay on faculty. If we could get you training in ERCP, would you consider staying? So I said yes. And so they arranged through my the division director and the division director at Duke that I would go to Duke, and they would pay my third year as my quote advanced year, even though people didn't call it advanced endoscopy training. Dr. Cotton labeled it as third tier biliary training, or pancreatic biliary training. And so that's what I did. So I was able to go to Duke and work in his unit for that year.
Tell me about that year.
Yeah. Well, I mean, I had a lot of excitement, and I thought this is going to be the best year of my life. And in retrospect, it really was a good year. During that year, it was a little disappointing because I realized when I got there that they allowed their second and third year fellows to rotate through ERCP, as well as one other trainee that was accepted as an advanced trainee, and then me. So probably there was at least 7 or 8 people vying for about 1,000 to maybe 1,100 ERCPs, which for a program is obviously a lot of ERCPs, but for each individual, really, it was only about 135, I think, 130 to 135 reps that I got. Now, having said that, what I did was I He also was ahead of his time in that he had his own fluoro unit. Obviously, a lot of places didn't. We didn't. And so, but he also had a conference room where there was basically televised live into the room, 2 rooms at once. So when I wasn't doing procedures or trying to do my own research, I was watching everybody else do ERCP. And the conferences were all related, the surgical conferences, the M&M conferences were all. So it was a total immersion in ERCP. And even though I didn't get to work really much with Dr. Cotton, maybe 2 weeks out of that year, it was, in retrospect, really a good immersion into the field. I think I mentioned to you before maybe that I would sneak into his office at night. He had VHS tapes of ERCP.
Breaking and entering.
Yeah. Well, he left the door open. I mean, so as I recall. And he had a lot of VHS tapes because he would travel all the time internationally. So you would see tapes of other experts doing live cases. Because, again, the young people have to realize we didn't have, internet. We couldn't watch anything. All we had was books, of which the Duke Library had a lot of ERCP books that you probably never heard of. And I've thought about it more, and obviously that was probably because Peter Cotton was there, and he said, we need to put these books on the shelf. So I read, some of them weren't even in English, and I read through those and read and watched. And so when I was done, I was really pretty sure I knew what I needed to do. The question is, could I myself be able to execute that with the limited number of hands-on cases? And when I went back to UAB, I was sort of expected to be like the guy and really pretty much the only one really doing ERCP. And I thought, this is a lot of pressure. There are high expectations. So I left to come home about a month before I actually started as faculty. And during that month, my wife helped me build this crude ERCP model, which was a PVC pipe in the short scope position and a descending duodenum made of a baby bottle, which is plastic, clear, colorless, and that was the descending duodenum. And then we beveled out 2 pieces of tubing and put them in what we thought was the medial wall of the duodenum. And then UAB had a fiber optic scope, ERCP scope still on the shelf. So I brought that home with a catheter. I remember it was a bullet tip catheter. Hardly anybody uses those anymore. If you've ever even seen it, it's got like a metal bullet on the end of it. And all you needed was a lamp as your light source because you got the fibers back to your eye. So you didn't need anything. Obviously, you didn't need insufflation. And so really what I did was at least a couple hours a day of just passing catheters, putting right on, left on, watching the endoscope and the duodenum, what it would do when you put right, left, tip up, tip down, and just played with it really so that almost everything I did, I didn't really have to think about. That would be more automatic because little did I appreciate when I got back, I didn't really have a radiology technician. So while I'm doing the procedures and sedating the patient, because we did our own sedation, I'm putting films in and out of the film processor. You would imagine the fluoroscopy back then was horrible. Honestly, I can't even remember if there was a last image held feature. I don't think there was. So when you turned off the fluoro, you didn't have an image to look at. So you'd have to either keep the fluoro pedal on or take the hard copy, and then I would run it through the processor. Obviously, as a stone case, you could see a stone, sphincterotomy, take it out, take a bunch of films, develop them later. But for complex cases, you had to I had to run the film in and out of the film thing, which was good at the university because it was almost automatic. You put it in, it spits it out. But at the VA, I literally had to go into the dark room, eject the film, feed it in, and then go out on the other side and then wait for it to come out, So, the other thing when I got back from Duke, they assigned me, and this continued for 5 years while I was there, 6 months of hospital service and 6 months of consult service. So literally I was busy doing all the other inpatient work I had 2 outpatient clinics with no fellow that were general GI clinics, and I did all the endoscopies that were generated from them in my spare time. And then the ERCP was almost like a side project. So I was building that practice almost independently from what was going on with taking care of all the inpatients and my outpatients and et cetera. So, and going to the VA to cover there. It was across the street. So, you know, it was really more than a full-time job by far, but I was able to, over the course of 5 years, build up to I was doing close to 1,000 a year myself for the last 2 years, but it steadily went up like 250, 500, et cetera, to almost 1,000 a year, and trying to publish on top of that, which we can go into, was also challenging.
Yeah, I kind of wonder to myself, like, kids these days, they would never understand this, like building your own plastic model. You kind of wonder to yourself, can we force our next advanced fellow to build a plastic model?
Well, probably not.
And practice a couple hours a day.
Yeah, probably not. I mean, it's interesting what both fear, it was a combination of a little bit of fear in terms of not fear of, more fear of failure than fear of anything else, but that I felt like a tremendous load. But, I've always been like that. I've always perceived probably things like more pressure on myself than other people would think, that I have higher expectations for myself than I think other people do. And so, I didn't want to fail. And I wanted to build a practice. I wanted to be successful that way, but not only that, I wanted to be, successful recognition-wise nationally, which, was a whole other kind of thing that I decided as well.
Absolutely, and burning the midnight oil while you were at it.
Yeah.
Nowadays, people don't quite understand working those types of hours.
Yeah. Well, the other, first of all, nobody really ever talked about work-life balance.
Right.
They only talked about work. And I'm not saying it's certainly not the probably the right thing when you look back at not really having any, you have more concern for really your job and your work. But that was sort of probably, I'm a boomer, right? I'm a post World War II, baby. So that generation had the greatest generation in front of them, as they say. And I think really work ethic was the word of the day rather than work-life balance.
Absolutely.
And the teaching of, hard work equals success.
Right. And I think
which is still true.
That lesson, right? I think came from your parents to some degree, right? Came from your upbringing.
Yeah. My parents were very hardworking individuals. My dad enlisted in World War II when he was 17, so he didn't graduate high school. That he finished, he was only in the war a year. It was over a year after he enlisted. And then he got his GED, and then had a really interesting life of like bouncing around for careers of all kinds of things. And then eventually got into selling real estate, large tracts of land, real estate. So he's a big, like, land broker, I guess, if you will. And real estate manager. And then with the company that he was with, he began traveling a lot. And then it was initially nationally and then internationally. And so he was gone a lot. We never had the perception that he didn't wasn't care about us, but he wasn't really home a lot for a lot of years. And my mom equally started selling real estate in South Florida in '69. And that was kind of a boom of real estate. And so she was kind of a workaholic as well. She sold day and night. She would take phone calls 10, 11 midnight, write contracts on pieces of napkins in the middle of the night, and became very successful. So they were both extremely hardworking people, but they really left my brother and I to our own devices, if you will. So, which was good, but we're both amazed that we both turned out as well as we did, honestly, with little supervision.
Right, and I think I think you and your brother are very, very close, even to this day, and I think it's very inspiring for all the rest of us. And growing up, you had an interesting hobby as well, which I think you seem to have preserved throughout the course of your lifetime. And I'm quite convinced that this has a lot to do with your personality and how you've developed as a person and how you've developed in your career as well. Tell me about this racing thing that you do.
Yeah. So it's interesting now to talk about it, and people recognize it. At the time, you know, when I applied to medical school, I don't think anybody really understood, but it's clear, like you said, that it really did help form me. So when I was 9, my dad, he used to read the Miami Herald every Sunday, which at that time was like this big around. And in the paper, there was a layout, which interestingly enough, I found on Facebook. Somebody posted the exact article of what led us into go-karting.
Oh,
and
cool.
It was the Miami Herald, and it was a full page or 2-page about go-karting. And he said, you guys want to go down there? It was in Miami, which is about 35 minutes away. So we went down there, and I remember saying, wow, this is really cool, but they're really fast. And because we're talking about even back then, compared to like what you would go to with a rental go-kart where it putts around, even back then they were relatively fast. And my dad said, well, we'll buy one. And we bought one. It was terrible. It was the worst piece because we didn't know what we were doing, right? So we invested in this thing that was a piece of garbage. And little by little, I got sort of slowly better and better. And then we got another cart, always initially used carts. And then by the time I was about 12 to 13, my brother really started to figure out a lot of how to adjust the chassis. And then he became an engine builder, actually. And he became a fairly successful 2-cycle engine builder. These are 100cc 2-cycle engines. So over time, I started winning local races, and then I would go to the regional races, and I started winning regional races. And then I won 2 Grand National Championships in 1979 that were televised on ESPN. And that really, like you said, that the whole experience of, you know, getting into something where, you know, you have to basically build yourself up in terms of, you know, not knowing anything, not really having a lot of help, and competing against adults. That's the other thing, is people think, well, you were, you know, mostly racing against other kids. That's true when you're in the younger age group, but once you get to be 16 and over, the ages actually I'm not talking about 50-year-olds, but most of the really successful people were in their early 20s to mid 20s. And at 16, I'm racing against people like 5 or 10 years older that have been doing this a lot longer. But it was, you know, these were really fast. Like the ones that I raced, what's called a twin Yamaha, and that would go almost 100 miles an hour if the straightaway was long enough. And so, you know, you're wheel to wheel. It's open wheel racing, literally. So any contact from wheel to wheel can cause a serious flip and injury. So, you know, you're basically this far off the ground going almost 100 miles an hour with no protection, no seat belts, no roll cages. And so you kind of, you know, you have to have almost a no fear attitude. You can't be completely, devoid of any concern, but it's more that you have to make split second decisions. You're thinking about a lot of things at once. You're tuning the carburetor, because back then the carburetors are very erratic. So you're driving and tuning, and you're, you know, so that I think really did, like you said, form, you know, quick decision making. You have to be decisive. You have to be aggressive. You have to have like I said, a lack of fear. And I think all those things probably helped me along the way for sure.
Yeah, but at the same time, also like consideration of detail, right? Like,
Right.
you know, yes, it's like sure, maybe
Right.
a lack of fear, but also considering the
Right.
finer details.
Oh, for sure.
So that you
And
don't wind up getting yourself killed.
Well, and a lot of
Right.
self-analysis.
Yeah.
I mean,
Yeah.
what you end up doing is when you fail, you have to figure out, why did we fail? What could we have done differently? How can we, work harder to overcome whatever we did the last time? And so you have to have a lot of self-reflection of honesty of why are we not doing as well as we want to.
Yeah, absolutely. And I think that translates into your career in so many different ways.
Yeah.
So I guess it really probably factored into you being an outside the box thinker.
Yeah.
Right?
Yeah, I think so. Yeah. I think the more I think about it, I think there's a couple reasons that. One is because my parents were really sort of a hands off, and I was an independent thinker. I didn't ever feel like I had tremendous limitations, and I always questioned when people of authority would say certain things. I would say, why? Like, why? Even all during residency and fellowship, if somebody would say, well, I think that 25, we didn't have access to data like we have now, right? So people could spout data, and every time I would say, that doesn't make sense to me. Where does that come from? Prove it to me. Why does that, or I would second guess, like, we do this. Why do we do this? Have you ever asked yourself, why do we do it this way? Why can't we do it a different way? And I can give you a lot of, of examples of that.
Rules are meant to be broken.
Right. Exactly. Yeah.
And you're a bit of a MacGyver in many ways. You kind of do whatever you can to solve the problem that's in front of you.
Exactly. And that's exactly sort of my approach is we can solve things if we, mechanical issues, of course. We're not talking about medical issues, but I felt like we could solve a lot of things endoscopically that were traditionally managed with surgery. And, one of the things that you and I talked about was, I think when, because I had the hospital service at UAB so much of the year, and these patients that were admitted, if any of them needed a complex, endoscopic problem and what we could do at that time, they were right there on my service. And one of the things that the surgeons did at that time was accept transfers to our service with minimal, like, are you okay with that? So you find out there was somebody that they accepted because they needed medical tune-up, and they would be there and they would round on them, the surgeons, until they said, okay, we're ready to operate, or we're actually not going to operate, which did happen sometimes where you had a patient where they said this patient's actually too sick to do anything. And so having these patients as my patients, if you will, because I was taking care of them every day, I felt like I was invested in their care and that they were as much my patients as the surgeon's patients. So if I could offer them something and they weren't offering them something, or they were delaying, why couldn't I offer them something? And so that's kind of what led me to say, hey, maybe we can fix this with an endoscope.
I'm sure that was not always well received by the surgeons.
Yeah, well, for sure. And that's one of the things. I mean, people ask me when they go into fellowship, what's the best way to build a practice? And I sometimes I say, you don't necessarily have to do it the way I did it, right? The way you do it is to build it cautiously and to grow and integrate and all these things. But, that was not my personality. It was sort of like, let's go, let's do something. And so I think, surgeons certainly wanted, and some aspects still want you to ask permission, right? And that's probably something that I know it was something I didn't really do a lot of times, is ask permission. So
you kind of grew up without boundaries.
Exactly. So I was like, I'm going to do what I'm going to do. So, and fortunately for me and for the patients and, for everybody, those things, again, I took risks and the vast majority of time that worked out. I'm not going to say there weren't patients that I would do things differently on along the way. And obviously you learn a lot by experience. There's that quote that experience comes from good judgment comes from experience, which comes from bad judgment. That's and so that's. But again, I didn't also have people, because nobody else was pushing the boundaries or doing some of the things that I was doing. My colleagues really couldn't give me that much advice of what to do or not to do, because they weren't really doing it. So in a way, I was, it was also isolating because I was doing it on my own. But I really, I was all in, and I really, enjoyed it.
And quite frankly, I think as you were saying about surgeons and the environment, everyone's environment is different too, right? In terms of like what their colleagues are like, how supportive are they, how open-minded are they, how much are they willing to talk to you and collaborate and build something together. I think everybody, again, going to the mentality of a junior faculty asking for how to set up a practice, everyone's environment's a bit different. Exactly. I think they have to fine-tune and be flexible with it, just like you were. You're arguably, you basically did what you could with the environment that you had. And being the only person at UAB, arguably, you don't even know what the boundaries are.
Correct.
Right? In that time and in that era.
Absolutely.
So I guess and that really kind of builds us into talking about one of the key contributions that you've made. Tell us about the story of pancreatic necrosectomy.
Yeah. Okay. So interestingly, when I got to UAB, there was a lot of chronic pancreatitis. So I saw a tremendous amount of people that had chronic pancreatitis and true pancreatic pseudocysts. You also have to remember this was a time when people had not defined what the various fluid collections are in the pancreas. It was in the surgical literature a little bit, but even then it wasn't like widespread. And even radiologists would call every fluid collection for a long time a pseudocyst without distinguishing. And so I was draining a lot of pseudocysts, which interestingly enough, I had never seen when I was at Duke. And I saw a patient with a pseudocyst, and I remember calling Dr. Kazarek, who I'd met while he came to talk at Duke while I was there. And I called him up and I said, I want to drain a pseudocyst. How do I do that? And he basically said, all right, sit down, grab a piece of paper and a pencil, and I'll tell you. And basically he said, look for the extrinsic compression, use a needle knife, puncture, drill right through with cautery, inject, because you had a double lumen, make sure you're actually in it, coil wire, balloon dilate, and put 210 French double pigtail stents. So I started doing that, and of course we didn't have the US, and I don't think really any place truly had. Well, they had a US, but nobody was doing therapeutic because, again, it was radial scopes. You got to remember, radial came before linear. You couldn't do anything anyway. But so with the pseudocysts, really, if you didn't get either a perforation or you hit a vessel, they did amazingly well. I admitted everybody overnight because that's what people did, and they went home the next day, and things were great. So I got a call, and I remember they said, we have a patient who had post-ERCP pancreatitis, has a pseudocyst, they can't eat, it's very big, can you drain this pseudocyst? And so I looked at the CT, and as you know, the CT looks very homogeneous because you can't see the underlying debris, and I punctured, and I remember seeing very chocolatey fluid, which was a little different than most of the clear fluid, but I put 2 stents in, admitted overnight, she did great, sent her home. And then 72 hours later, she calls and says, I'm having fevers to 103. And I was like, that's odd. So why don't we come in and get a CT? And I remember where I was, who I was with, put the CT up with, again, there was no digital imaging. You looked at the CTs with the radiologist, and it was air and a lot of solid debris because the liquid was out, and now you could see the air and the solid debris. And I turned to him and I said, what can I do now? And he goes, I think you're going to have to call the surgeon. So I called actually a true pancreatic surgeon back then, who, total twist of fate, I had no idea at the time, he actually trained at the Mayo Clinic, but had been at UAB for most of his career. And he took the patient to surgery. He called me around 10 o'clock at night. I was home. He paged me or called me, and he said, You have no idea what you're doing. This is not a pseudocyst. This is pancreatic necrosis. You could have killed this person," and hung up the phone. And I was, I felt terrible. And he did send me or direct me to an article that had talked about the various types of fluid collections. I think it was written by a guy named Charlie Yeo, Y-E-O-H,
Okay.
who was a pancreatic surgeon, I think, at Hopkins. And so I on the heels of that, so this patient's in the hospital, open necrosectomy. They did it the old-fashioned way, leave the abdomen open, and it was just like a terrible hospital course. And almost at the point where she was going home, I got a call about a patient who was at the children's hospital, but he was a 16-year-old who was an offensive lineman. That he was all intents and purposes an adult, and he had idiopathic pancreatitis, quote, pseudocyst. I mean, the two of them were bookend cases when you look at their images and their time course and everything. Can't eat. So I go in, drain it, send him home. Same thing, 72 hours later, fever. I bring him in, get CT scan, the same thing. And I'm like, oh my, what am I going to do? Because the surgeon is going to absolutely kill me. So I call up Dr. Kazarek and I said, what is there anything I can possibly do? And in his gravelly voice, he says, well, Todd, he says, and he explained to me that if you look at surgical principles, and there was a guy at their institution at Virginia Mason that was doing early percutaneous work on necrosis, and using lots of drains and irrigation. And he said, well, you could supply irrigation by going down, putting in a nasal tube alongside your 10 French stents, and aggressive irrigation, and maybe you can get this kid through this infected necrosis, which obviously would start out as sterile, which I had then infected with my intervention. So we did that. I think I got him out of the hospital in a week, sent him home with his mom. They were flushing at home, and I think it took several weeks for that to resolve, and I got it resolved without surgery. And I thought, okay, we have a control, and we have the one that we treated, and you can clearly see they were identical cases, and their outcome was totally different. So I then recognized and talked with, so I worked a lot with more diagnostic radiology than interventional radiology, and they were very, very helpful to me, and we started thinking about these cases differently. How do we recognize this? What is this entity? So we clearly recognized it. So when I finished doing the 11 cases, I decided to write up the series, including the first patient, which included in the one of 11, which was the failure. The other 10 we had data for that were clearly these necrosis patients. And so I submitted for rapid review in Gastro, which at the time, the entire Gastro journal was based at the Mayo Clinic, because back then, journals there wasn't anything, again, electronic. So the easiest way to run a journal was to have as many contributors in one location so you could sit down and have meetings, because otherwise you have to mail everything out, right?
Right.
And because when you submitted everything in paper and duplicate, and all the images were, old-fashioned Mavograph or whatever you call it, glossy images, and in 4. Everything had to be in 4, one for the editor, one for the reviewers that they would mail out.
Wow.
So anyway, I submitted as a rapid, which they would make a decision, reject or accept within 2 weeks. And if it wasn't as long as it wasn't outright rejected, you could resubmit, like if it was major revision. So I got it back with 5 reviews. It was incredible, the number of reviewers, and each reviewer had pages and pages, and it was daunting. And one of those reviewers I recognized, because I, again, read all the literature I could read in the area, and I could tell the way the reviewer wrote that this was a certain reviewer. That was Peter Banks, and who's considered one of the godfathers of pancreatitis, or the father of medical pancreatitis, one of them. And so It just so happened that I got an invite from David Lichtenstein, who was working under David Carlock, who, by the way, David Lichtenstein trained with Peter Cotton the year before I went and trained with Peter Cotton, and was with David Carlock at Brigham and Women's, and he sent out the invitation, and can you talk about this stent symposium we're having, because you do colonic stents and nobody was doing colonic stents. So I said, yeah, I want to come out, but I want to have an audience with Peter Banks. So they gave me 30 minutes with him while I was there, and I said, hey, you're the guy. I know you're reviewer number 3, I think, and I really want to, let's talk like, off record, so to speak. So we talked for about an hour, really, about what this was, and he said, the question I have is, what is this thing you're draining? Because we labeled it as endoscopic therapy for pancreatic necrosis. That was it, the initial. And he said, you have to figure out what this is. What is this? But at that time, nobody had really called, like, they had distinguished between early and late. It was all pancreatic necrosis.
Right.
So I went back, and obviously it was very helpful, and I went back and I was working with a diagnostic radiologist named Desiree Morgan, and she said, let's come up with a name for this. So we called it organized pancreatic necrosis, because she said it went from this disorganized process to something that is organized, that we defined it as an entity which represents the previous necrosis, whether it be pancreatic or peripancreatic or both, that has defined itself and organized into a drainable collection. And so that was never officially adopted, although it was people wrote, followed along until the revised Atlantic symposium or criteria that defined it as walled-off pancreatic necrosis. And that's really jump-started my career. And then I think I mentioned to you that the following year there was this massive symposium on acute pancreatitis in Bern, Switzerland, and I got an invitation to speak there, and I was just like, blown away that, how could this be? Like, I get invited to Switzerland a year later, and all these famous pancreatic surgeons were there, and all the famous pancreatologists were there, and David Carlock, who had, obviously there were several endoscopists, and I thought, oh, this is going to be great. They're going to welcome me in with open arms, and no. And it was somewhat, I think about it, and I don't want to bring it up to the Nobel Prize and H. pylori, but it was probably a lot of things in medicine, right? Where you're just, there's no way this is really going to work. They didn't believe it. I presented numerous cases and images and all this stuff, and they just like, no, this isn't really, And so I left sort of somewhat scarred a little bit, but I knew it would work because I saw it myself, right? I was a believer. You didn't have to convince me. But funny enough, one of the people that was there was a guy named Eugene DiMagno, who was the same guy that handled my manuscript through the Mayo Clinic, who I someday would become colleagues with, right? Because I went to Mayo. But at the time of this, I had no idea I was ever going to end up at the Mayo Clinic. And I remember I walked into that symposium and I saw his name badge and I said, oh, hi, Dr. DiMagno, I'm Todd Barron. And he turned around and said, you're the guy, you're that guy. And I'm like, what? He goes, that guy, I can't believe I accepted that paper. And, I don't know what I did. And, apparently, I guess he got a lot of pushback on it. I don't know. But he just, and I was like, hello, well, hi, and even as an early colleague, it took many years before he was finally convinced that actually was going to work. And he apologized to me later before I left Mayo to say he was wrong. And so that was, it's very gratifying, to see what it has become from something that was, fringe at best to standard practice. That's the kind of thing that's really kind of amazing,
But Dr. Kozarik was an early believer, though. He wrote the editorial that came with the paper.
Yeah. And let me go back, because, again, you and I may have talked about this, but in order to get that paper written from its inception to getting it submitted was an unbelievable amount of work. You have to remember, again, everything back then was paper, right? So I remember going in on nights and pulling all the charts on these patients, and you think, well, it's only 11 patients, but it's like, when was their onset of pancreatitis? You're going through charts, and when was the day of intervention, and how many days were in the hospital? And these are things that, you're basically writing all this down and pulling every single image, so that what you have really represents, that, and then never having written a massive article for gastro. I remember spending endless, literally all-nighters writing that paper and looking at data and weekends. And Hootie and the Blowfish had just come out with their first album, which was called Cracked Rear View. And I had a DVD player, and I would just listen to that over literally continuously, like all night long. Like I know every song on that album. And so, to see it to its fruition, and when it got, and so I told you that, the funny part of the story is that Dr. Banks had to recuse himself when I resubmitted it to gastro. And of all people, the person that was his sub, if you will, was Dick Kozarek. So obviously he knew it worked, and he had talked to me, and he was a believer, and he gave me the inspiration. And I remember being at DDW. I remember where I was in the hallway. I'm pretty sure it was San Diego. And he said to me, "Oh, your paper in gastro is going to be accepted." I didn't even know that at that point. And he said, and they didn't want to take it because there were so many naysayers, the other reviewers. And I told them, this is such an important piece of work that if they don't publish it, I'm never going to review for gastro ever again. And he had that much, impact in pushing it through. And, I can't even remember. There wasn't a PubMed back then. I think there was something called Ovid, OVID, like an early search engine. Yeah. But they were very, 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 very delayed. Like from the time something was published to the time it made it to Ovid. So, of course, now every month I'm running to I don't know what month it's coming out. They don't tell you what month. So, I'm running to the mailbox every day, looking for this thing. And one day I open it up, and sure enough, there it is in gastro. And I, turn quickly, and there's my name, and, and then it says, "See editorial page, blah, blah, blah." And I flip to the editorial, and I read, it says, "Endoscopic therapy for pancreatic necrosis, perspectives on skunk poking." And I was confused, and I remember the day. I remember the weather. I remember everything. It was a nice fall day. It was clear. I ran in and I called his office, and I said, "Well, what is this skunk poking thing?" And he's like, "Oh, Todd, you take one of these sterile necrosis and it's not doing anything, and then you stick it in there, and then it's infected and it's ugly, it's nasty, it's like skunk, like poking the bear, basically." And right. That, like I said, that really kind of put my career on a high trajectory of, for success. And, at the time, it's important for you as an individual, but you have no way of knowing that if this is going to be something that dies out. It was just cool that it was the first, it was my inception idea, first author, very little help. And so it was, extremely, satisfying, of course.
No, absolutely, and now this is recognized as a historical moment in our field.
Yeah.
But it takes the right person and the right mentality to pull this off, actually. Right. And in getting to know you through this whole interview series, kind of realize that you're really the type of person where if you do something very very forward thinking and very outside the box, you don't drag your feet on getting this thing published. Like, you get it out before anyone else does.
Absolutely.
Because that replicates itself in other firsts that you've done, right? I think you have a story about you were the first to publish on the transduodenal drainage of the gallbladder, on
endoscopic transrectal abscess drainage. Yep, and you're absolutely right. And that sense of urgency, nobody taught me that. It was sort of the kind of thing where I would do something and I would recognize immediately this was something never done before.
Right.
And I also somehow had the wherewithal to realize that you can't, like you said, you can't just say, well, I did it and I'll wait a month and nobody else will do it. And before you know it, somebody else has the same idea. And so, yeah, knowing that I didn't have the infrastructure to do anything really truly prospective, and I wasn't really trained clinically in clinical research as a prospective study creator, if you will, because when I worked with Joel Richter, everything we did was retrospective. It was really good work, and he taught me how to do really good retrospective research, but that's all I knew.
Right.
So I knew if I only had one or two patients on anything and it was novel, that would be it. People were like, case reports, whatever. And to me, if it's first in human sort of things that might change how we do things, one case might be good enough, and that's all I had at times.
Right.
So
right.
yeah, or small series. Once I did a number of things, I was like, okay, I think it's time. I've proven, at least to me, that it's better than the natural course or what we were doing surgically.
Right, absolutely. And I think you have to, in especially with some of those cases, you really have to kind of like go against the grain and stand firm in your convictions as well, right? I think
exactly.
you talked about your first experience with colonic stenting, right? I think that was an interesting one.
Yeah, I mean, there was a lot of for sure a lot of pushback because it wasn't mainstream.
Right.
And the colonic stenting was somewhat similar to what you said about being MacGyver. Is I had a patient who had literally no other options. At least my first patient, which was a woman that had a rectosigmoid cancer, and at that time, cancers were almost always late because they were no screening. Right? People don't realize screening colonoscopy didn't come out until about 2002, 2003. So I was doing this in 94, 95 maybe, and she'd been resected, radiated, recurred, re-resected, recurred, and had a lowish, complete obstruction, was in another hospital for 2 weeks with fecal and vomiting, and was transferred to me with an albumin of like 1.3. And even the surgeon said to me, if we do a diverting ostomy, she may break down with an albumin that low. And so all I had in my hands was the first generation esophageal stent, which a lot of people don't know that Boston Scientific's first esophageal stent, they couldn't get around the patent of what the wall flex was. They eventually bought that patent, which was
it's called the Wall Stent
system.
Company, right?
Correct. Wall Stent was a company that originated in Lausanne, Switzerland. And here's a trivia fact that most people don't know. The guy that invented the wall stent, his name was Val Sten, Wallsten. And so they put a T on it, it became the wall stent for him. And he was an inventor. You can look that up. So the delivery system, the way they got around the patent at that time was the withdrawal system was not called a release system. It was called a protection. And the stent was constrained with a gelatin material that once you pulled the sheath, you then had to put water through the channel to dissolve the gelatin to let the stent expand.
Oh, interesting.
So that was the first FDA-approved esophageal stent. And so I remember I put that stent in, and she left the hospital again in less than a week. It took her a while to resolve because she was actually had a lot of ischemia in her large bowel at that point. And she lived for 3 more months with no reobstruction. And so, and I remember telling people, I'm doing colonic stenting, and they said, that's ridiculous. And then to me, it just made perfect sense, right? You have a stricture of lumen and you have a stent you can put in there. And again, that kind of goes back to right time, right place for my training, which was before I left in May. It was May of 93. I recall the first wall stent made it to the United States. And of course, Peter Cotton was putting in the first wall stents. And I remember helping deploy one with Dr. Cotton, and swear on my life, he said, you may have found your calling, which is so premonition, right? I think he had an interesting, his humor was very British and very dry, like he would literally hold your hands and move your body and cannulate for you, and then he'd step back and go, "Nice job." Right? So when he said, "You found your calling," when I deployed a wall stent, I'm sure he was being very facetious at that point.
Right. He's a funny character in and of himself. So.
Yeah.
Now, as I understand, I think it was you or your colleague who proposed the term the enteral stent.
Yeah. So,
right?
So the company, again, this is all very funny. Wall Stent's U.S. headquarters were in Minneapolis, Minnesota, right?
Uh-huh.
And again, this is before I ever considered. And one of their lead representatives flew down to Birmingham and said, "We hear you're placing stents in the colon, and including tracheobronchial wall stents, which were 16 and 18, I think, millimeter, but they were not TTS, and they weren't very long, but you could get them in the left colon, right? So you could put a wire in, and then it was non-wire guided colon stent." So they flew down and they said, we want to build you a colonic wall stent. And I said, great. And so my specifications were, I want you to build me the absolutely biggest diameter you can achieve with your biliary or tracheal stent design, which were exactly the same, stainless steel, that can go through the biggest diameter of a colonoscope, regular, They didn't have pediatric or PCFs at that time. They were just all whatever. So I said, as long as it can go through the channel, and it can be go long enough to go through small enough to go through, and long enough to go through a colonoscope. And I remember working with a young colorectal surgeon named Phillip Dean, who I have no idea where he is at this time, and he had just came as a colorectal surgeon from Mayo again, which is crazy. And I said, hey, I was all excited because he was the only one that would work with me on stents. Yeah. Nobody else would want to even think about it. And I said, they want to build us a colonic wall stent. And he calmly said, why don't we just call it the enteral wall stent, because it can be placed anywhere in the GI tract if you do that. So I went back to them, and they named it for years. It was called, before they divided it up into colonic and duodenal, it was the enteral wall flex, and then the enteral wall stent, and then I think it was the enteral wall flex, and now it's. But anyway, that was.
And now we call it enteral stenting.
Yeah.
Yeah.
Right.
So it's interesting how these terms come from. So, kind of how do you? By the way, how do you approach patients when you have something like this?
Yeah. So, let's start with the easiest part.
Yeah.
For example, we'll take, and to me, the low-hanging fruit is somebody that literally has no other options.
Right.
Or says to you, I don't want whatever they have. What do you have? So some people will say that, right?
Right.
So I gave you 3 cases right away that we've already talked about. One is the colonic stent, the transrectal abscess drainage. They had offered percutaneous, and the only way they could say that they could get that was to go transsacral. To reach that, because it was so posterior,
right,
they would have to go needle and go right through the sacrum. And they said it's been done, but it's horrendous. And the first gallbladder patient was somebody that had unresectable hilar cholangiocarcinoma, was not a surgical candidate, and the only thing we could offer was a percutaneous drain, which we'd live with the rest of her life. These kinds of things, right? So, or the aortic aneurysm, where we can fix this, but you'll die. Surgically, it will be 100% mortality. Those conversations are much easier. You go in and say, look, this is what I can offer you. It's your last resort. I haven't done this before, but I think I can do it because I've done this, which is like that, right? So even the gallbladder was like, well, we've been draining pseudocysts and other collections through the wall. I think I was one of the first people to even describe a postoperative large abdominal abscess that had nothing to do with the pancreas that I drained without EUS with a 19 gauge needle that I designed, which is another thing we can talk about. So you basically say, look, this is a similar principle. It hasn't been done before, but the likelihood that we're going to have success and avoid the other thing is high. And if they're like the case in the aortic aneurysm, if the mortality is 100%, they have nothing to lose by trying this.
Right.
They might die, but and this guy, by the way, that I did with the aneurysm, I followed him and called his daughter every year for 5 years, and he made it 5 more years. So
That's
he
amazing.
got 5 more years of life out of a procedure that could have killed him, but the other option was 100% mortality. You know, it's a little bit trickier, obviously, when there's other therapies. Like, again, when I was doing colonic stenting, at the time, ostomies were standard of care. But, and you and I both know, people with ostomies don't, or, you know, people that even the thought of it, of living with their intestine outside their body is enough to say, maybe there is something better. And yes, you know, and it sounds rational what you're talking about, right? I mean, you basically sit down and say, this is how it works. I think this is going to be our outcome. We don't really know, but it's up to you. And, you know, if you look at the two options of an ostomy or a stent, you know, and if you have a backup plan, like in the aortic aneurysm case, there's no backup plan.
Yeah.
But in a colonic stent failure, you can still go to surgery. It might not be as nice and pretty, but you can still have an operation and come out with the same overall probably result, right? If you recognize a complication immediately and you manage it immediately, right?
Absolutely.
Surgically.
Absolutely. Yeah, it's a very interesting. I was thinking about that aortic aneurysm case. It's one of those things where that's really like a one of a kind type thing. You'll never find another one of those.
Correct. Yes, exactly. It was like you said, the stars had to align,
right?
You know, perfectly that this person had this disease process and this many other comorbid illnesses that made surgery basically, you know, 100%, you know, and the age, you know.
And also, by the way, the recognition that, you know, when you consider that specific scenario, right? Like, a lot of people don't realize that when an aortic aneurysm is fixed, that sac is still there. And it doesn't have any flow for the most part, but it can get infected.
Yes, absolutely. Right. So that was actually a learning experience for me, too. It's funny. You think you know a lot about medicine in general,
right?
And you know, and like you said, in your mind, you think, oh, a stent goes in there, it collapses, and there's nothing there.
Right.
But to your point, the aneurysm sac is still present; it's just excluded from flow. And so when they called, to me, it was like, okay, we have a CTA. There's no extravasation. That space is protected as long as you can assure yourself you remain in that space. You know.
Right.
So.
Well, what was the surgeon's reaction later?
So it was interesting because it was interesting consult because our APP that at that time had the images up. She said she got called by somebody in thoracic surgery that said this would be 100% mortality. Is there something we could offer? And I never linked who that person was or how they understood that was even a feasible thing. So my hat's off to whoever thought maybe I could do something. And then
name gets around.
And then they got and then they ended up getting subsequently transferred to thoracic surgery after I did my procedure. And so I never really got to connect with that person. So it's kind of, again, you know, and in fact, the night that I did it was a Friday night at like 10 o'clock because anesthesia said, this is not a case we're going to do in the endoscopy suite. And I had finished all my cases at like 6:30 or 7, and then we set up for later. And I remember calling him after I aspirated pus. I was trying to get a hold of him, like, you want me to drain this? And I didn't hear from him. I'm like, well, I guess we're going to do it. You know, and so we ended up putting
it's implied permission.
Exactly. Aluminum opposing metal stent, and then away it went. Yeah, it was pretty. And again, that night, it was like, his case is going to be written up, and it's going to be, you know,
Captain America.
There you go. Yeah.
So you've alluded to this multiple times now about the Mayo Clinic, and I think it's we can't really get away without telling a story of how you wound up there.
Yeah. It's actually a really good story. So I'd done this ERCP in a room-wide gastric bypass, native papilla for a bile duct stone. And when you look back at it, I think I was lucky because limbs back then weren't as long. And again, we're talking, this is 1997.
Mm-hmm.
And at that time, I probably that was the one regret. I don't think I ever case reported that case. And there was a series that came out later of altered anatomy. But at the time, nobody had published on doing that. And I took a colonoscope, and I barely got there. I'm pretty sure I ended up having a pre-cut to get in, and I got the stone out. And I couldn't find anything in the literature other than Christopher Gustout, who was at Mayo, of course, had done a publication, I think even in Gastro, on room-wide hepatico-jejunostomy patients of ERCP. And so I thought, I'll just email him and say, have you ever done an ERCP? Because you've done it in this setting, altered anatomy. Have you ever done an ERCP in a room-wide gastric bypass patient with a native papilla? And his first response was, no. Would you like a job at the Mayo Clinic? And that's the way he was. He was very, upfront. And I said, and the backstory is that my wife was born in Rochester, Minnesota, because her dad took a job at IBM in the 50s, and the only thing in the 50s was Mayo and IBM. And so they left Rochester when she was 8. She grew up in Florida. We met in college at University of Florida, and all she could talk about, if it ever came up, was how much she remembered the bad memories of Rochester, Minnesota, being frozen, again, pre-global warming, the 50s, the cars don't have heat, the houses don't have heat, there's no insulation, She walked to school in the snow. It wasn't uphill both ways.
Right.
And she was like, when we got, I proposed to her, she said, I'll follow you anywhere in the world except to Mayo Clinic or to Rochester, Minnesota. She didn't say Mayo. And so when he sent me this response, my response was, no, it's too cold there, because my wife said she'd never go back and it's too cold. But then his response was really, really thoughtful. Like, I really, it was one of these things you wish you'd printed, saved, whatever. And it was a very thoughtful email that he was developing this developmental endoscopy unit. And I think it was with Olympus support, and that he was going to build this up. And one of the early people at Mayo that was doing ERCP retired. And the way they fill is based more on need than it is somebody's reputation, honestly. It's like, do we have a need? Can we get somebody? So I went home, I talked to my wife, and she said, well, I guess you could look at it. And I said, okay. And then I didn't hear anything from him for months. And I just kind of said, well, maybe that's one of those things. It's not going to, whatever. Because the ball was in his court when I said, okay, let's go ahead and, do something or whatever. And so his boss, a guy named Nick LaRusso, famous hepatologist, had a lot of interest in PSC, was giving a lecture on a Friday, and they said, does anybody want to meet with Nick LaRusso while he's here? And I said, yes. And so this Friday, I was supposed to meet him at 5, and 5 goes by, and 6 o'clock, I look at my watch, I'm like, I wonder where he is. So I called the office, the main office, and said, where's Dr. LaRusso? And they said, he's about to leave. And I said, where's he going? They said, he's going to go to his sister's house. He has a sister in Birmingham. I said, how's he getting there? He said, we're going to call him a cab. And I said, no cab. I ran to my office on the way over. I printed out my CV. I was actually pretty good about keeping up with my CV. And again, this is like 90, maybe early 98. And I pick him up, I take his luggage with him. I go to the parking deck. I drive him. I say, Christopher Gustout had mentioned there's possibly an opportunity there. And he said, well, yeah, we thought we had somebody, but it fell through. And so we talked. I dropped him off. And that was probably 6:30 on a Friday night. And by Monday morning at 8 a.m., he called me in my office and said, we want you to come for an interview at the Mayo Clinic. And I said, okay. And that led to me eventually getting hired there.
Was your wife okay with it?
So she cried initially, and well, more of the crying came after the first interview. The first interview I went by myself. She said, well, at least just go look, and you got to satisfy your curiosity and go look. And then they asked me for a second interview, and then she, I think it was during the second interview when she said, yeah, he's probably going to take this job. And what's also funny is we still had some land that we owned there that her mother and her dad bought, which was in an area that was undeveloped even at that time, that we ended up selling eventually as well. And then went up there and we saw where she grew up in her house and all that, which was kind of interesting.
Very good. And you stayed at Mayo for a pretty good number of years.
Yeah.
Right.
Yeah.
Until interventional EUS started coming along, and then a series of events led you out of Mayo Clinic and to UNC. This is a very interesting story in and of itself, as your journey into EUS, because I think most people these days don't realize that you're not just a pioneer in ERCP, but you're a pioneer in EUS as well, but also very you had come into the EUS world much later than the rest. Tell me about your EUS story. This is very interesting.
Thank you. So, when I first got to Mayo, EUS was just still somewhat in its infancy. And in fact,
you saw it at Duke, even, didn't you?
Yeah. So there was a guy named John Affronti, who was one of the attendings in biliary when I was at Duke. There were 7 biliary attendings. He was one of them, and he had his own room, and he had a radial scope, and he was trying to figure it out. Probably there were a lot of places at the same time. If you think about it, Peter Condon has ties to Rob Hawes because he trained Rob Hawes. And he worked with Rob, and probably Rob was probably developing EUS at the same time on his own. And I'm just assuming this is what was happening. And think about it. People with endoscopy in many centers outside the United States, the EUS was actually and still was done by radiologists. I don't know if you appreciated that, right? The radiologists that do upper EUS, because they understand ultrasound and endoscopists didn't, and they were trying to figure out images. So I saw it. I didn't know what I was looking at, and most people didn't know what they were looking at. And I what's the utility of this, right? And at Mayo, EUS was separate from ERCP, and the fellowship was separate from the ERCP fellowship. And it was, again, like most places, radial initially, diagnostic, FNA. And so it was 2012, I went to Italy.
So what if someone needed both EUS and ERCP?
Oh, yeah. So if they needed you, again, we were giving our own sedation. So they would go into the EUS room, get their EUS, and then they would get wheeled in the ERCP room sedated because it was Demerol and Versed and everybody was asleep. And you'd obviously consented to them for both, and then they would have their ERCP and then...
By a different person.
Correct. Yes. Absolutely. And there was only one person at that time, so the people that there were 2 people that did EUS and some ERCP, and their volume was probably 10% ERCP and 90% EUS. So it really was very separate. And I knew people had talked about one day these things are going to merge, and that'll be someday, and I didn't know when someday would be. But I went to Rome. Guido Castamagna invited me as faculty, and they said there's a patient with both duodenal obstruction and biliary obstruction, and this guy, Alberto Largi, is going to do a US drainage procedure of the biliary tree, and you're going to do the duodenal stent immediately after. So I'm standing there watching him, and they had a hot axios in Europe then, and he did a colorectal duodenostomy in, I think it was around 8 minutes. And I was absolutely floored. And I said, this is it. If I don't, the future is here, and I can see the future, and it's right now, right? And so I went back and I said, I've got to figure out how to get trained in the US because I'm going to be, left out, and this is where it's going. So toward the end of 2012, I actually kind of already knew without anybody telling me that I probably wouldn't be able to do EUS there because it was so separate, and I felt the environment wasn't going to. So in 2013, I took a month of my own time and went to Hyderabad, India. I asked Nagi Reddy, because I'd been there several times already as a faculty, and said, hey, I know you're doing EUS and some therapeutics, but I want to at least just put my hands on EUS scopes. Can I come over? And he said, yes. So I spent a month in Hyderabad on my own in 2013. And when I returned, it was not met. Let's just say that wasn't met with a lot of support, and was basically told I probably would never be able to do therapeutic EUS. So for the rest of that year, I followed Mark Topazian, was the only one that would let me, and I was listed as a fellow that year, all through 2013. Whenever I could, if I was on admin time, or even if I was in the unit and I had a break, I would be doing EUS with him. I don't know how many I got done. Maybe I got close to 80. I don't know. And but I had done 324 EUSs in 24 working days in India. 324. So I had the 324. Let's say in April. Followed Mark Topazian for the rest of the year, and then negotiated the contract with UNC that I could do 3 more months somewhere else of EUS. And when I was in India, somebody had whispered in my ear, there's a guy in France who is amazing named Laurent Palazzo. Maybe you should contact him. So I had asked some people in the States, and nobody could really figure out a way to get me trained. Bill Brugge actually offered to train me before, when he was still at Harvard, but he said it's going to take a year for you to get a Massachusetts license. He goes, apply right now, but I could never get a license. So I knew I had to go outside the United States again, pretty much. And so I emailed Dr. Palazzo, and he said, yes, you can come over for 3 months. And I did either EUS FNA or purely diagnostic, but I probably got to do another 300 that month, or that 3 months. So between all that, I probably had many more than most. Well, I know I had many more than most advanced fellows, and I also had just about 20 years of endoscopic experience at that point outside of fellowship, and doing interventional stuff without EUS of needles, guide wires, catheters, and sticking all kinds of things. And so I kind of knew once I figured out EUS, I'd be able to do therapeutics pretty, because I understood that aspect. And so fortunately, it seamlessly went from one thing to another, and I just took off. And
you were already in your 50s, I think, when you learned EUS.
Yeah, so when I started solo, I was almost 55.
Wow.
I was 54, and I was, 55 and a half. Yeah. So I've been doing EUS now for a little over about 11 years now. Yeah.
You would never think that, looking at what you've accomplished.
Thank you. But,
you also don't look your age.
Thank you. I appreciate it. Yeah, I'll be 65 in less than 6 months.
Yeah, you definitely don't look your age. It must be the go-karting.
Well, I think it's a lot of things. One is I have really good genetics, and I've fortunately been working out with weights since I was 36. That was my New Year's
picture of you and Cheyenne Irani. Yeah. You're like stacked.
Yeah. I'm probably in better shape now, actually, than I was in that picture. But he came to Cary, North Carolina, to work with the full thickness reflection device, because you can't order it unless you've done the training there.
Right.
So Cary is close by, and he stopped by and did a workout with me. So that was where that came from.
That's amazing. I mean, you're and I think it's really fascinating that you were able to then train yourself to do EUS, seek the opportunities, go abroad. And again, I think this just has to do with boundaries and perspective and all the stuff that we talked about in the beginning of the interview. It continues to propel your career. Do you find that you're at a ceiling yet, or are you still going?
I think, I mean, it's I think you and I discussed it offline I think that what I've realized is I think that therapeutic endoscopy, as long as you keep persevering, you can make incremental gains as long as you literally can scope, if that's what you want to do. It's asymptotic, especially if you stay, let's say now that I never get out of the realm I'm in, I think I will still make gains of things. And, there are procedures that I've done. It's funny how it works. You'll do a procedure and stop yourself and say, wow, that's a procedure even 2 or 3 years ago, I don't think I could have completed that. Like, for example, hitting a 1 millimeter peripheral duct in somebody who has some kind of biliary obstruction and their ducts are dilated centrally, but they're just tiny out, and, things like that where you're like, I'm sure I could not have done that case, and so I think if you continue to challenge yourself and take on things that you previously thought would either be difficult to impossible, you make those, incremental gains.
Absolutely.
The massive revelations probably not so much anymore, but you never know, right? Because you never know what's going to come along. And that's what's interesting about the field, is that if you continue to keep an open mind and think, I could possibly do this, maybe you can,
Yeah, and I think...
I'm sorry to interrupt, and it's like you said, the right patient has to come along and the right circumstances to allow that to happen, which, to the point of the aortic aneurysm, will anybody ever see a case like that? Maybe, and maybe that'll help somebody else, but it's not going to be widespread, of course, like necrosis, right?
Right. Now, there's so much serendipity and opportunity involved in all this. You consider yourself a lucky guy?
Yeah, I do. I really do. Yeah. I mean, it's funny, if you ever watch the movie Forrest Gump, I say that's one of my favorite movies, and people will look at it why, and well, that's a fairly simple movie, and the whole movie is about how much of your life is total chance and how much is fate, right? That comes up constantly if you watch that movie. And he happened to be in the right place at the right time, making history by being somebody who's not really smart, but took the opportunities that presented themselves. Right. And so I think that's really a lot of my life has been very, very random, and somehow it's all really kind of worked out. I mean, I literally probably couldn't write the script of my life if I had to, and it didn't exist, if you know what I mean. It just was like, there are people that I didn't mention during the course of this that I met that changed my life. Well, let me go back. I should recognize somebody I didn't recognize in the article, but in my Schindler speech, there was, I got on an elevator. I was this lost puppy trying to do there was a society at UF called the Pre-Professional Service Organization, still there. And you could volunteer. It was a way to volunteer to put that on your CV, right? So I walked down to Shands Hospital. I try to figure out where this place is. I get a little white coat, I'm like an orderly and following people around, and I have no idea how I'm gonna get into medical school. I mean, I'm like I said, if you look young now, I look like probably a 16-year-old. And somebody on the elevator one day, a neurosurgeon who was very empathetic, said, "You look like you could need help," basically, right? He goes, "What are you doing? What are you trying to achieve? And I told him, and he basically took me under his wing and helped me with applications for medical school, which I can guarantee you I wouldn't have known how to do, and I didn't have friends. I mean, I studied, but I didn't really have anybody. You would think I would have plenty of people to know how to help me, but my roommate the first year was an architect. He wasn't going into medical school, and so he couldn't help me, right? And so he helped me to do some little bit of lab research and helped me do my things, and then he actually became the godfather to my children, and if I hadn't met him, would I ever got into medical school, which I barely got into. And, then when I got into medical school, I meet somebody who, helps me to study and get better, and that was sort of random. And then, so it's just along the way, it's just a lot of randomness. And then I asked myself, was this meant to be, or was it really just a bunch of randomness?
But also it takes the prepared mind, though. You know, you have to take that. You know, not everyone who has luck and opportunity to walk past them will recognize that. And take advantage of it too.
And again, more open-minded to an opportunity that, like you said, presents yourself that you could either brush off and say, well, yeah, maybe not, but you have to take it and run with it and do the best you can. And I think that's, in some ways, I hate to say it was almost out of desperation, you know, like, you know, where you, I think, again, what the karting taught me is if you define your goal, first you have to define your goal, and then whatever it takes to get what that goal is, you can't lose sight of that's what you're trying to achieve, even if things look, you know, bleak. You know, at the end of my first year of college, I had a 3.0 and I was struggling, and I'm like, this is never going to get me into medical school, right? And it was like, I just have to work harder and, you know, figure it out. And so once I think that people just need to really hang on to what they believe in and don't let go, you know? Absolutely.
Along those lines, when you look back, what do you consider to be your greatest achievement?
Well, other than producing my kids, my greatest achievement in medicine, I mean, there's a lot of, you know, part of it is what the legacy is that you leave. You know, when you're gone, people won't necessarily remember you, and it's sort of a sad state of affairs, but it is what it is. But they will remember the people that you trained are kind of like your legacy, and they're the people that will live on, that will continue to do your work and teach other people. And so in some ways you kind of will, your greatest achievement is the people that you can train and then can carry the work on that you started, just like the work I'm doing really is carry on from Peter Cotton and Dick Kazarek, and that's a carry on from people before them, right?
Absolutely.
But I guess I'm most proud probably of you know, the gallbladder drainage and the necrosis, which became long lasting and really changed what people do. I think those things eventually would have been figured out. It would have been not me, but somebody would have figured that out, or not figured out, or done it, whatever. And then the ERCP book, I've gotten so many people that have been very appreciative of the book, that said that it really changed them, or you know, either was, you know, such a good teaching book, or that it really inspired them. And that's probably one of the biggest as well.
Absolutely. And, you know, as we kind of wind to a close, just want to thank you again for a very deeply insightful and wonderful interview. And my closing question that I ask everyone is, for your advice and wisdom, you know, what advice do you have for future generations who wish to become as innovative as yourself? Yeah.
Well, I think there's a couple things. Like I said, one is, you know, set your goals. Right. And stick to your goals. And those have to be things that are driven by the heart, you know? It's along the lines of what my other advice to people is, don't just get into something because it sounds like something that you would need to help complete your career or to get a job. I mean, if it's something that doesn't really speak to you and you're doing it just because it's the thing to do right now, that's probably not going to serve you well. I think what I was very fortunate that I was able to grasp something that spoke to me, that I truly believed in, that this is going to be the way to go, you know? And so that serves you very well, because you're not working, you're working, but you're in the moment, you're in the process, you're enjoying it, and you're saying, I'm going to do this. And it's, you know, not, well, I have to do this today, and I trained because it was a good idea, but I don't really like it that much. You know, that's not, so number one, find your passion with that, whatever it is within GI. Two is obviously try to find the best training you can. Everybody does that. Three is you need to connect with people. And I think that's obviously much easier than it used to be, is connecting with other people that in your field that can help you. and fortunately, the world is so open now that you can find people that may not be right in your institution that can guide you. I was fortunate enough to make that connection first face to face and then by phone and then, with Dr. Kazarek.
Right.
But he was my mentor from far away, and I try to do the same to other people. But find those people and work hard,
Absolutely. By the way, you shared an office with Basil Hershowitz.
Yes. So it was that was the nicest office I ever had. I was very lucky to get that office. It was.
And you're a fellow.
No.
No,
I was a first-year faculty.
First-year faculty.
So they gave me an office. One of the older guys had just retired, and Hershowitz. It was a nice common atrium, and then his office was on one side, and my office was on the other side. And I would go to him and talk to him, and I think I told you this. He had every book of every GIE issue every year bound and hard copied.
Uh-huh.
And he said to me in 93 or 94, one of those talks we had, he said, take all these. They're outdated. I'm never going to use them. And I whenever the first issue was, I literally stacked them up and then went through every single one of them.
Uh-huh.
And they were really easy to do. I mean, the first, we put an endoscope and we saw a spot in the duodenum and it was this. And they
Right.
were all case reports. So there was really very simple for many years. And then but it was fun because you could see the evolution of endoscopy and the history of endoscopy right in front of you, like EGD, colonoscopy, then ERCP. And so I had read really every article, and the name that kept popping up to me was Richard Kazarek.
Uh-huh.
I don't know. It's good to have an interesting name, right? So it's an interesting name, and he was doing interesting things. And so even before I met him, I identified with this person because they were doing some really interesting, innovative things. And again, it spoke to me like this is the kind of thing I want to do, right?
Right.
And that's how I kind of gravitated. And fortunately enough, for me, again, lucky, right?
Yeah.
He was invited to Duke the year I was there to give a talk. And I was able to connect with him, and he was able to guide me throughout my career.
Right, and he's still. You guys are still friends to this day.
I still talk to him. I still call him. I call him less for help than I used to, but I can tell you, even in the last year or two, I'm like, I've never seen this. I bet if anybody's seen it, I'll send them an image. Like, let's say it's a weird pancreatic anomaly or something. I'll say, have you ever seen something like this? And more often than not, he still says, yes, I've seen that. So, which is really nice.
Well, very good. Well, thank you again for a phenomenal interview.
Thank you.
I really look forward to seeing this out and posted and everything.
Thank you.
But thank you again. It's truly been an
what
honor
you've
and a
done.
pleasure.
You've worked hard with this project
you.
as well, and I appreciate what the journal is doing.
Absolutely. No, I think as you mentioned, surgeons tend to be better at preserving their history than endoscopists do.
Exactly.
But there's so much that we can do to try to preserve our own history in endoscopy.
Yeah, absolutely. So,
yeah. Thank you.
Thank you.
Barron just shot into that new position. Barron is going to be pushing now. We're on the white flag lap coming up. And here is your leader, Goldberg, Barron, and Ito. They're lapping apart there. Let's follow them around here. Here they come. This is your race, ladies and gentlemen. This is for the national championship. This one lap is going to determine the national champion right now in this class. This is your 100cc McCullough Light, Chuck, and boy, what a race we've had here.
Oh, I haven't seen one like this for several months, and it is not over yet. Watch this man make a move here in the second slot. And Ito, look at Ito come up the inside and get right ahead of him. Ito's got the pole. Ito made it. Oh, he's not quite.
Barron just took the lead coming into the corners.
Ito hangs on
Here
to
they come, and here is your champion, number 11, Todd Barron is your national champion in McCullough Light with a superb bit of driving. He's holding his hand, and what a great finish to a race. He waited to the last 200 feet to win this thing, and he held back there in third the entire race, and he knew he had the stuff, Chuck. He knew he had it to win.
He certainly did.
So your winner in this particular heat was Barron, and consequently wins the national championship, number 11, this young driver from Hollywood, Florida. And I bet he's just so happy about winning it.
And in the 2 position finished was Michael Goldberg out of Miami. And George Ito moved up into the 3rd spot, and this possibly could give him a 3rd place overall in this 100cc McCullough Light, the most thrilling race of the day. Here are the official results of the 100cc McCullough Amateur Light.